This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Cancer Medicine, published in 2026, titled Clinical Outcomes and Prognostic Factors of Stereotactic Radiotherapy for Spinal Metastases with Epidural Spinal Cord Compression Grades 1-2.
This is a timely topic, Alara. For years, the gold standard for spinal metastases with cord compression, especially for radio-resistant tumors like renal cell or thyroid cancer, has been separation surgery followed by stereotactic body radiotherapy, or SBRT. The idea was always to create a gap between the tumor and the cord to allow for high-dose radiation.
Exactly, Dr. Aris. But as SBRT technology has advanced, we've seen more clinicians attempting to treat these patients with SBRT alone, skipping the surgery entirely. The problem was a lack of solid clinical evidence for this approach, particularly for patients who have mild to moderate compression but no vertebral instability.
Right. This study specifically targets that middle ground, epidural spinal cord compression, ESCC grades 1 and 2. For our residents listening, can you remind us how they studied those grades?
Of course. They used T2-weighted MR images to prospectively grade the lesions. ESCC grade 1 was defined as a tumor with epidural extension abutting the spinal cord, but without displacement. Grade 2 was defined as a tumor that actually displaces or compresses the spinal cord, but importantly, without circumferential tumor extension or complete obliteration of the cerebrospinal fluid space.
And that's a crucial distinction. We aren't talking about grade 3, where you have circumferential compression and no CSF visible. This study was a single-arm prospective trial. Tell us about the cohort.
They followed 65 patients with a total of 71 metastatic lesions. Interestingly, a large portion of these were traditionally radio-resistant tumors. Renal cancer made up 69% of the cases, followed by lung, thyroid, and breast cancer. The median age was 60.
Before we dive into the SBRT specifics, we have to talk about stability. As neurosurgeons, the first thing we look at is the SIN score, the Spine Instability Neoplastic Score. If the spine is unstable, SBRT alone isn't the answer. How did they handle that?
They were very strict. Any patient with vertebral instability requiring surgical intervention was excluded. In their cohort, 54 lesions had a SIN score of 0 to 6, which is stable, and 17 lesions scored between 7 and 12, which is potentially unstable. No unstable scores were included. They also excluded patients with severe pain who couldn't lie flat for the procedure.
Let's get into the how. They used the CyberKnife platform. Walk us through the dosimetry and fractionation they used, because that's where the curative dose comes in.
This is one of the most important parts of the paper. They used a 3 mm margin from the gross tumor volume to the planning target volume, or PTV. However, they retracted the PTV where it overlapped with the spinal cord to protect it. They used the Monte Carlo algorithm for dose calculation and delivered 1 to 5 fractions.
And the dose selection wasn't random. It was based on the lesion volume and the degree of cord compression.
Precisely. They followed a specific protocol. If the lesion involved the vertebral body but occupied less than 2/3 of the volume, or was a small lesion in the appendages, they gave a single fraction of 24 GI. If it involved the entire vertebral body, or one side of the appendages, they gave 30 GI over 3 fractions. If it involved the vertebral body and bilateral appendages, they went up to 40 GI over 5 fractions.
So the final decision on fractionation really came down to the spinal cord's tolerance limit. They used the 70 to 80% dose line standard, ensuring the PTV covered more than 95% and the GTV covered 100%. That is a very high precision delivery. What did the results show regarding the primary endpoint?
The primary endpoint was local progression-free survival, or LPFS. The results were quite impressive. Out of the 71 lesions treated, only 3 showed local progression. When they compared ESCC grade 1 versus grade 2, they found no statistically significant difference in LPFS, with a p-value of 0.769.
That's a major finding. It suggests that even if the tumor is displacing the cord, as in grade 2, SBRT can be just as effective as it is for grade 1, provided you have the right technology and dosing. Did the multivariate analysis show any specific factors that influenced the efficacy?
Actually, the multivariate analysis confirmed that the ESCC grade itself was not a significant factor affecting the local treatment efficacy of SBRT. This supports the idea that SBRT alone can achieve outstanding local control for these grades.
Now, let's talk about what every neurosurgeon worries about when we hit the spine with 40 GI, toxicity. We're always looking for radiation-induced myelopathy. What did they find?
The toxicity profile was actually quite manageable. They reported no cases of spinal cord injury. There was one case, about 1.4% of the cohort, that experienced late neurological damage of grade 2, but that was it for the serious neurological concerns.
What about acute side effects?
Esophagitis or oral mucositis was seen in about a third of the cases, but only one was grade 3. Nausea occurred in about 20%, mostly grade 1. They also saw acute pain in about 4.2% of cases, and some vomiting. Overall, the authors described the toxicity as minimal.
This is compelling. If we can avoid a major separation surgery in a patient with a stable spine and ESCC grades 1 or 2, we save them from the risks of anesthesia, infection, and a long recovery. The paper essentially argues that SBRT could be an effective alternative to the combined approach.
It does. They conclude that for patients with metastatic tumors, ESCC grades 1-2, and no vertebral instability, stereotactic radiotherapy alone provides outstanding local control. It's the first study to really provide a curative dose framework for this specific subset of patients.
It's a paradigm shift. We've moved from radiotherapy is just for palliation to SBRT is a definitive local treatment. However, we must emphasize that this applies only to the stable spine. If there's instability, surgery is still the first move.
Exactly. And the study notes that the fractionation mode, whether you choose 1, 3, or 5 fractions, should ultimately be guided by the spinal cord's tolerance limits as defined by the AAPM standards.
Excellent summary, Alara. This study provides much-needed clinical evidence for our MDT meetings when we're deciding between surgery and primary SBRT. It seems the knife isn't always the only way to protect the cord, provided the radiation is precise enough.
It definitely gives us more confidence in the SBRT alone approach for these specific grades.
Well, that's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast.
We'll see you next time.